and navicular. The joints involved include the talonavicular joint, the subtalar joint, the calcaneocuboid joint, and the ankle joint. With respect to the talus, in Clubfoot, the body of the talus is seen to be smaller, the neck orientation in relation to the body is changed, and the position of the talar head and joint surfaces is also altered. So I've tried to demonstrate in this slide those features pictographically. The neck of the talus is deviated more medially and plantarward relative to the body. In addition to the exaggerated plantar and medial posture of the neck, there is a change in the torsional relationship. In the normal infant foot, the head is rotated with respect to the long axis of the talar neck. So the picture on the right is the left foot, where the talar head would normally be torted externally in relation to the neck, but the shaded red shows the clubfoot talar head internally torted. The calcaneus is again smaller. The orientation and shape of the articular surface are changed with underdevelopment of the sustentaculum. The anterior articular surface is directed downwards, medially and inverted, and the angle of the posterior facet reduced. The navicular is elongated and wedge-shaped, broader on its lateral and dorsal surfaces. So now looking at the relationship between the bones, the deformed talus lies in increasing degrees of equinus within the ankle joint. The medial angulation of the talar neck gives the subtalar joint a medial spin, and the calcaneus follows, reducing the talocalcaneal angle with the interosseous ligament acting as a fulcrum. The calcaneus rotates in more than one plane, with the anterior calcaneus moving down and in, and the posterior calcaneus moving up and out. The heel appears to be inverse because the calcaneus rotates through the subtalar joint in the coronal plane and horizontally. Deformity is maintained by contracture of the joint capsule and capsular ligaments, which are grossly affected by the pathology. There is contracture of the capsule and posterior tibio-talar ligament. The talofibular and tibiofibular ligaments are contracted. The tibiocalcaneal, talocalcaneal, and calcaneofibular ligaments are shortened and thickened. The Achilles is short and tight. Tibialis posterior and the long flexors are contracted. On the posterolateral aspect, the perineal sheath is contracted and thickened. And then coming to the midfoot, the calcaneocuboid joint is displaced medially. The navicular is displaced medially from the head of the talus, and the talar head is exposed. The metatarsals are fixed in equinovarus. These pictures are from Ippolito's paper and show cross-sections through the level of the tip of the medial malleolus. On the left, the pathological left foot, seen here on the right, shows the displacement of the navicular with the exposed talar head, and the navicular butts the tip of the medial malleolus. The contractures of the soft tissues on the medial side maintain the cava varus, including tight joint capsules, contracture of the deltoid and spring ligaments and the plantar ligaments. The plantar muscles and abductor hallucis are also contracted, contributing to the equinovarus. Muscle compartments of the leg are involved with contracture of the triceps surae, tib posterior, and long flexors, and the perineal tendon sheath is thickened and contracted. The calf can be seen to be smaller and remains so throughout life. There's also an abnormal relationship of muscle fibers to connective tissue. So just going back to the clinical examination, I just want to take this opportunity to emphasize the importance of examining the whole child. And at first presentation, it's critical to take a full history, assess the appearance of the baby, examine the spine and hips, and exclude conditions associated with CTEV, such as arthrogryposis or spina bifida. The deformity can be seen on inspection with the medial crease demonstrating cavus, adduction, and supination of the midfoot, the lateral curvature of the foot, and the deep posterior crease demonstrating equinus. We examine the emptiness of the heel, looking for the position of the calcaneus and the rigidity of the equinus. We like to score our babies using the Pirani score, which I know will be mentioned later, and we do that at each visit to assess progression of correction. On closer inspection, the flexibility of the deformity should be assessed. We not uncommonly see a reasonable number of children with foes with positional clubfoot, and it's important to assess the correctability of the deformity. The tailor head is palpated by first identifying the distal fibula and then moving the thumb distally and anteriorly. With the other hand, the forefoot can be abducted around the tailor-navicular joint. The positional clubfoot will allow simultaneously dorsiflexion at the ankle, which won't be seen in the pathological foot. And remember to look for signs of the atypical foot, which again will be discussed later, but these pictures just demonstrate the abnormal medial crease that can traverse the whole foot with an atypical clubfoot, and the short elevated hallux that may raise concerns. Thank you. I'll pass over to my colleagues.
Thank you. That was excellent overview and very informative talk. Any questions or any comments? Okay, so since we don't have any questions, we'll move on to the next talk by Tim Nunn on the classification systems. Thanks.
Good afternoon and good evening, everybody. Thank you again for the invitation. So I'm talking from Ethiopia, the capital of Ethiopia, Addis Ababa, which is about 2,500 miles west of Kerala. So we see a lot of clubfoot here, and the vast majority of which is untreated, so-called neglected. And my talk today is looking at scoring systems for delayed presenting club feet, particularly focusing on the PAVA score, which was developed here in Ethiopia. So, as I've mentioned, the majority of the feet that we see are delayed presenting. Infant clubfoot services here are very sparse. The majority of those under the age of 10 still do respond to Ponseti principles of manipulation and casting. Essentially, we needed a score that predicts cast response. The surfaces for delayed presenting clubfoot are the moment in development, with provincial towns really taking some of the burden off of our institution in providing this care. What we wanted was a score that essentially predicts the response to casting, and so that we can determine which case needs referral to our centre, which is Cure Ethiopia, and which could be managed more locally. So in terms of clubfoot, obviously there's a vast spectrum of deformity and problems. And in this presentation, I'm not talking about the atypical clubfoot. As you can see here on the left side, there's a profound amount of plantaris and cavus deformity. And I'm not talking about syndromic clubfoot with this constriction band syndrome case, or neurological foot either, or recurrent for that matter. So this is looking at the boy, which is on the right-hand side of the screen, which is a congenital idiopathic clubfoot. So we've been managing these cases, as I'd said, up to the age of 10 years of age with serial manipulation, casting, and then a surgical approach, which is limited and requires a posterior Achilles tendon lengthening, followed by tibialis anterior tendon transfer at the end, once adequate dorsiflexion has been achieved. the existing scores are exceptionally well known, particularly the Pirani score. But in the older foot, there are some issues. And as it turns out, it is not very helpful. There are no posterior and medial creases to observe on most of these delayed presenting club feet. And we did a study which showed that there was in fact very poor agreement between observers on whether the talar head was covered in these feet or not, and whether the heel was empty or not. And there did always seem to be a curved lateral border and significant cast atrophy. So reducing the discrimination effect of these elements of the scoring systems. So we concluded that the Pirani score wasn't super helpful for our population. And in addition, we wanted to see what the amount of deformity was after some correction. So you can see here, this lad on his left foot has significant standing deformity, but is in fact very flexible. So what we wanted to do was have a scoring system that looked at fixed deformity. So our scoring system that we developed has the acronym PAVA, and it depends upon measuring fixed deformities of these angles below. So P is for plantaris, A for adductus, V for varus, E for equinus, which is equinus at the hind foot, and rotation around the talar head. Those elements are then summed and multiplied by an age-related factor to give us the PAVA score. We know from experience that it's not only the age of the child, but it's also the severity of the fixed deformity which contributes to resistance to casting. So here we have a diagram which shows these elements, plantaris, and that is that is measured. I'll show in a moment an example. The apex of that is around the calcaneal cuboid joint. Adductus, again, the apex of that is around the calcaneal cuboid joint. Varus at the hind foot, equinus at the ankle, and rotation around the talar head. So the Clubfoot score the PAVA score, was developed from the Demeglio score and used those measured angles. And it was combined with age as a multiplier to give a maximum score of 30. It's not exactly the same as the Demeglio score. And what we've done in the scoring system is to define out the plantaris and the equinus. So they're two separate aspects of this score, which is combined as one in the Demeglio original. We looked at the inter-rater and the intra-observer variability for 4 raters and found a very reasonable agreement. And when we grouped them for mild, moderate, and severe deformities, we found excellent agreement. So I just want to go through a worked example to try and explain this further. So here is the first bit, which is plantaris. And as you can see here, plantaris is relatively mild, 10 degrees, and anything between 0 and 20 degrees scores a 1. So this score is 1. A is for adductus, and here you can see there's a moderate amount of adductus, and measured angles of between 20 and 45 degrees scores a 2, so this scores 2. Varus is a V, and here you can see it's quite mild, and we see that quite a lot in these delayed presenting club feet, in that the varus is not a significant feature. That scores 1, as it's above 0 degrees, but less than 20. Equinus is often a very significant component of the deformity. And of course, when the ankle is plantigrade or in neutral position, that would be 0 degrees of equinus. But here you can see the amount of equinus is actually 58 degrees, which is above 45 and scores 3. Finally, after rotation around the talar head, so we've drawn a line down the foot, down the tibia, intersecting with the exposed talar head, and then up between the second and third toe interspace up towards the exposed talar head, and measured the resulting angle, which is 44 degrees here. That's less than 45, but greater than 20, which scores a 2. So for these measured angles, they're converted into those points for plantaris, adductus, varus, equinus, and rotation, and then added up. And then the sum of those component points is multiplied by an age-related factor. And you can see the age multiplier is displayed on the screen there. This child is 8 years old, so the multiplier is 2, and the PAVA score, therefore, is 18 out of 30. And from our experience, around 18 to 20 is in fact the cutoff for cast correction resistance. So we know that a score over 20 and above will likely be resistant to casting. That doesn't mean to say that casting will be ineffective, but for our triage tool, we know that it would probably be best done at a specialist center, anticipating further problems down the road. So we did a validation study on this to look at whether the score was valid in terms of, did it correlate with the number of casts needed to correct the deformity and with pedobarography. Our hypothesis was that it would take more casts to correct a higher PAVA score, and those with higher PAVA scores would have smaller footprints and greater pressure points. So we looked at 100 Clubfeet, all children between the ages of 2 and 10, and all walked on a pedobarograph mat, and we charted the number of casts to full correction. We discontinued casting if they'd had 9 changes and had either plateaued or had not responded. So looking at our results, we found that there was a significant association between the PAVA score and the number of casts needed to correct the midfoot. So here you have the PAVA score along the x-axis, and those that successfully corrected and those that failed casting on the y-axis. And you can see there seems to be a clear cutoff around 18 to 20, whereby a PAVA score of that amount essentially means that casting is not going to correct the midfoot. So our conclusion was that the ease of correction is related to the PAVA score, that out of 100 feet, about 11% failed to respond fully to the casting, and a PAVA score of 18 to 20 predicts failure. In terms of pedobarography, we showed that, as expected, that the smaller the footprint area, the higher the score. And in terms of pressure, the higher the pressures, the higher the score. So our overall conclusions were there was a good association between number of casts to achieve correction with the PAVA score, and that it was a useful score to predict success of cast treatment at the age of 10 and under in these idiopathic feet. I wish to thank you for listening to this talk.
Thank you, Tim. Any questions from any of the faculties? Yeah, Atul, please.
Hi, Tim. That was a great talk on a new scoring system. Just one couple of questions. One is, did you also take into consideration the tibial torsion which they get at that age, the older children, whether that corrects itself as well, and whether some of your rotation, tibial rotation, the talar rotation also actually measured tibial torsion. And the other point is, if two children have a similar paver score, say age 5 and age 10, there's an age-related correlation between number of casts purely on the age rather than the paver score also? Is there any, can you shed some light on that?
Yeah, no, they're both excellent questions. Can I just address the second one first?
Sure,
So
sure.
with regard to the casting number and age, we found that both age and the severity of the deformity are independent factors when we look at response to casting. We thought that there may be a link, of course. The older child, the more difficult, and that's certainly the case. But it's not necessarily true that the older child, the more severe the deformity. I would say that it probably is that they are independent factors. And in regard to torsion, that's a very good point, that there is, of course, torsional deformity in the clubfoot, particularly this age. And we know that the lateral malleolus is rotated, posterior, and so to actually define torsion in the ankle joint as compared to the foot is, I think, it was quite a difficult thing to do. We didn't look at it in our study, but I think your observation there would be very valid.
Thank you.
Dr. Nunn, can I ask one question to you?
Please.
Can I ask a question, Dr. Nunn? Yeah, so this scoring system is applicable to orthorheumatic and other feet also, because there might be the difference of rigidness in the tissues. So are you applying the same for the neglected orthorheumatic feet as well, the same system?
Yeah, so please just confirm your question. Was it about arthrogrypotic feet as well and syndromic clubfoot?
Yeah.
So yeah, we didn't look at that in terms of our scoring system. We purely were looking at feet that are idiopathic, congenital club feet, and we discounted all of those previous cases, neuromusculars and arthrogrypotics and other syndromics. So yeah, I guess it could be used for that, but our purpose was to see if these feet were going to respond to casting or not. And as such, in bringing in other different types of clubfoot, I think would have made that assessment difficult, because of course we know that arthrogrypotics are particularly resistant, and other types as well. So we just wanted to have uniformity of the type of foot that we most commonly see here in Ethiopia, which is the untreated idiopathic.
I have one question. The equinus is the most difficult bit to correct. So was there any correlation between somebody having high equinus score or high plantar score and them being resistant?
Yes. I mean, so when we looked at the components of the score, you're right. Plantaris and equinus are very difficult. And I think probably that does run with age more than other features. So that children who have significant amount of equinus often have a dysmorphic talus and quite flattened, and that can be a real challenge to correct. So yes, I agree with you. There may well be sort of age-related aspects within the scoring system? It's another great question. Thank you for that. I hope I've answered it.
Thank you.
Yeah, team, it is excellent presentation. I have a question, Dr. Hitesh speaking. Did you check the inter-rater reliability of the specific component of the paver score? Like, I find it the rotation would be a little subjective. Whether would you find anything in your study?
We did look at that, and they were all moderately correlating and reasonably good agreement. I would say probably the one that was probably most difficult to get a good agreement was the varus, because drawing the angles on the foot was actually quite a challenge, because the heel's short, of course. So yeah, the way we looked at it, I'd say there was moderate correlation for all of these sub points, yeah, and overall reasonably good correlation.
Okay, and second question, what is the youngest age you can do the paver score? 2 years or even younger than 1 year?
Yeah, no, I think probably to differentiate the plantaris from the equinus deformity does take a larger foot. So that's why we went from 2 to the age of 10.
Okay.
So Tim, can I ask something?
Please.
Anyway, that was excellent work you have done. A couple of things. Is there a reason that the ones which correct well, are they children who might have some features of laxity elsewhere? Because we did publish a paper on that. But the laxity, if you have laxity elsewhere, probably the clubfoot is probably in the old classification of soft on soft, soft on rigid, rigid and rigid. So whether it works as soft or rigid over soft. When you come to syndromes like, say, Ehlers-Danlos or arthrogryposis, or say dysplasias where you get like dystrophic dwarfism, they also possibly you can use the same system, but the way we used to operate once upon a time, either you got overcorrection in the lax group, which is quite often the case, though it's surprising they all get Clubfeet. Whereas conditions like arthrogrypotics, which are rigid on rigid, they rarely we can get any correction, or they have relapses so much that if they get overcorrected feet, it's iatrogenic. So I wonder whether there will be a correlation between hypermobility scores of some sort to your paver, possibly in this group.
Well, I think that's a really good point. Just two observations on that. So in performing the score, you do put on a gentle correcting force onto each of the deformities that you're assessing.
Good evening.
So I think probably, so for example, in assessing rotation around the tailor head, you would perform the Ponseti maneuver, essentially by pressing your thumb onto the tailor head and trying to get a correction. So in a sense, that does account for some of the laxity that you do see, in that it's what we're trying to assess is fixed deformity. However, I do agree with you. I think there would be some good correlations there. We know in Ethiopia, possibly similar to India as well, that there's quite a bit of systemic hyperlaxity in a lot of our patients, and we have a large number of patients, for example, presenting with DDH and other things, which no doubt is there's hypermobility present. So yeah, we have tried in our best way possible, I think, in this scoring system to try and reduce the effects of laxity. And I think in the older kids, where they tend to have less in the way of laxity that prevents correction, but perhaps more in the way of bony deformity that prevents correction. Whether or not that would still hold true in the older kids, I'm not sure, but I think it's a very good point.
But you're right. What you're assessing is the bony deformity, which is what it's finite endpoint. You have to stretch it to an endpoint to measure all the angles. So I think it's a fair enough measurement in the neglected clubfoot, no doubt. The same thing is in what we used to see with multiply operated feet in the UK, was we don't have, usually they don't even stretch because of the scarring on the medial side. So there's a big difference between the two groups. But anyway, excellent work. Thank you.
Thank you.
Oh, is it possible to ask another question, Ashish?
Yeah, please do. Last question.
Yeah, sorry. I just wanted to know, have you ever considered X-rays for your feet in your assessment? And if not, why do you think they would be important?
Yeah, no, that's a good point. So X-ray evaluation, I do find useful sometimes, particularly over decision making. Once I've tried casting, particularly for those that are failing casting. However, in the initial assessment and in the initial treatment, I don't tend to use X-ray. And you know, the bone morphology after correction of these feet is often very abnormal, and I don't tend to find it a useful thing to measure in terms of these deformities. Clearly, that would be a large amount of exposure. I think there are some deformities where maybe X-ray would be necessary, such as cavus deformity. You probably need a standardized X-ray to measure that. It's very difficult to clinically measure that. So that's why we went to the more clinical measure, which was looking at the lateral side of the foot and looking for plantaris, which is the angle between the calcaneus and the angle of the fifth metatarsal. So I think X-rays are useful in my practice, but for management purposes, much later on in the treatment process, and when I'm struggling to get a good correction, particularly equinus correction for me. I want to see, and getting a decent X-ray is very difficult on these patients, and with the bony morphology and rotation and the torsion of the distal tibia, as we previously mentioned, it's very difficult to get a good lateral of the ankle to assess that flat top. So that would be the time in the OR that I would get a fluoroscopic assessment of the talus. I will also use X-rays if I'm struggling to get a midfoot to correct, and usually I'll be looking then for a blocking calcaneocuboid joint, which in these older kids is very oblique. Sometimes that can block the talar navicular full reduction. I hope that's answered your question. Thank you.
Yeah, thank you.
Thank you. Excellent. So we'll move on to the next talk by Mohan Belthur on casting and manipulation techniques. Mohan, please. Thanks.
Hi, good evening, everybody. Thank you for the invitation. So, as you all know, the Pansati method of manipulation and casting is a very specific regimented method, which mainly involves two parts. The first part is called as the casting, manipulation and casting. where the physician or the healthcare provider does all the work. And then the second part is called as bracing, where the parents do most of the work, facilitated by the healthcare team. And in between is, in most patients, require tenotomy of the tendo Achilles to correct ankle equinus. Well, why does this technique work? It depends on two things. It depends on the kinematics of the subtalar joint, and it also depends on the viscoelastic properties of the foot. These include things like stress relaxation and creep, which is time-dependent deformation. So the foot, like the body, composed of water predominantly, about 70%, and that allows us to use the viscoelastic properties to achieve this correction. So as you all know, the subtalar joint is formed by the talus sitting in the acetabulum pedis, as shown here. And this is very important to understand this anatomy, as this is what allows correction of the foot using the Ponseti method. It also depends on the axis of the subtalar joint, which is oblique in two planes, both in the frontal plane, as shown here, and in the sagittal plane, and therefore this coupling of movements. So whenever you correct varus and forefoot adduction, at the same time there is dorsiflexion through the subtalar joint as well. This is called kinematic coupling, and that's what. So this is the property that's used to correct the clubfoot using the Ponseti method. Another important principle is called as the calcaneopedis block. As you might have noticed here, the whole foot, including the calcaneum, moves under the talus. So you hold the talar head where it's marked TH on this model with your thumb, and the rest of the foot kind of moves under it as shown. So this is another important principle, because if you, for any reason, prevent the calcaneus from moving under the talus, like Hiram Kite did, then you will not get correction of the clubfoot deformity. So this is one of the important practical applications in this method. Also, we need to understand the two extreme positions of the subtalar joint and the foot in general, which is supination, which is a combination of forefoot adduction, hindfoot varus, and an ankle equinus, and termed as supination. And also recognize that the clubfoot is an extreme form of supination deformity of the foot, as shown here. And what we want to get to is the foot in the pronated position, where the forefoot is abducted, the ankle is dorsiflexed, and the hind foot is everted. So the Ponseti method, using the kinematic coupling of the subtalar joint, takes the foot from an extreme supinated position, which is shown on my left, to a pronated position, which is on my right. And thereby it corrects forefoot adduction, hindfoot varus, and to some extent subtalar and ankle equinus at the same time. So it's like a train following a railway track, and the foot follows the normal kinematics of the subtalar joint. So this is the important principle. So now coming to the position of how we do the manipulation and the casting. So there's a couple of important positions. So like I said, this is a two-handed manipulation technique where one hand rests on the lateral talar head, the thumb rests on the lateral talar head, and notice that the other fingers are encircling the leg anteriorly, not posteriorly, where you may run into the problem of blocking the calcaneus from moving underneath the talus. And on the other hand, grasps the metatarsals, even all the way up to the talonavicular joint to prevent any midfoot break. So the entire foot moves with the calcaneus underneath the talus, and this video is going to show that. So the thumb is on the talus. I would say the thumb should be even further forward where it's marked TH on the lateral talar head. And this is what you would see, how the forefoot adduction and hindfoot varus are corrected at the same time, and showing the correction to some extent of the subtalar equinus as well. And this shows the correction of the hindfoot varus as you move the foot out. Okay. So it's also important to achieve maximum abduction. Ponseti in his initial series did not abduct the foot to like 60 degrees, as he later did in his second paper in 1973. In his first paper in 1963, he had abducted to just around 40 degrees, which is the normal degree of abduction of infant foot. And he noticed that when he abducted it to 60, the risk of it coming back was much smaller because the medial structures were more stretched and even if they did recur, didn't come back all the way. So Hiram Kite's mistake, I just want to point this out, was placing the hand over the calcaneus where it says no on the left, on the bone model where it says no. So, and preventing the calcaneopedal block to move underneath the talus. So, and it took almost 50 years for the orthopedic finger to move from the no position to the TH position. So, well, now that we understand the principles of how the method works, what is this set? How do we do it? Or what's the setup? Usually, what Ponseti told me was we should usually keep the child starving. The baby is usually fed every 2 to 3 hours. So make sure and instruct the parents that don't feed the child for about 2 hours before you do the manipulation, because having a child that's at peace and not, thrashing about is very important for us to place a very good cast that doesn't have any wrinkles or ridges that could cause soft tissue issues. So when you feed the child 2 hours before, so the next feed would be while we are manipulating and casting. So have a bottle ready. If the mother is bottle feeding, have a bottle ready. If the mother is breastfeeding, sometimes I ask them to train the child bottle feeding. If not, I put the child in the mother's lap while the mother is breastfeeding. Obviously, mother should be comfortable with that. And then, we do the manipulation and casting. And usually the baby is quiet, distracted, as opposed to if the baby has just had a full stomach, has already fed. And if we go to mess around, because they are usually sleeping after they're fed, then, usually they don't like it. They start crying, thrashing about, makes casting, manipulating difficult. So usually you have the baby at the end of the table like this, as shown. The manipulator or the holder is, the attending if you have a really good casted. If not, if you have somebody that's not as well trained in the casting method, then you might be the caster as well. And then the other person would be holding. And then you usually sit, the manipulator or the holder sits on the side of the, for example, in this case, the right club foot. So the manipulator is sitting on the right side of the baby. The mother is sitting on the left side. distracting the child, sometimes by playing music or whispering to the child or feeding the child. And then the cast text stands at the end of the table as shown here. What materials we use is also important. Usually, Marquende and Pansetti say that, don't do it in a busy cast room where there's multiple castings, cast saw is being used, there's lots of sound. So you do it in a quiet room where the child and family with the couple of providers who are doing it. So the environment is quiet, calm, and reassuring. Also, what we need is, I use Webril cast padding, which is easily, which has a good feel to it, and it's not constricting, and then you can easily apply a very good padding. How we pad is also important. We usually start off with 3 rolls right at the end of the foot, and then very little padding in the rest of the foot up until the knee, where you just 1 roll of padding overlapping by 50%. And then again, 3 layers right at the groin, so that there is no skin pressure at the edges of the cast. And also, it's not like a fracture cast where it's loose to allow for swelling. It's more conforming. I would not use the word constricting, but it's more conforming. So there's very little space for the foot to slip in the cast. That's very important. So those are things that, like Marquende as well as Ponseti stressed a lot when doing the casting. Then the other important thing is manipulating before casting, as shown is here. This is important again to assess how far you can go. You don't want to, you just want to use 2-finger pressure, not anything more than that. And it's important to manipulate. And then the manipulation sequence follows the mnemonic cave. So you correct midfoot cavus first with the first cast, because the forefoot is relatively pronated relative to the hindfoot. So you need to bring the hindfoot, the forefoot and the hindfoot to the same degree of supination. That you can do by elevating the first ray as shown here on the left by this arrow, and then also in the picture here at the top, and then supinating, bringing them both into the same degree of supination, and then applying the cast in the same position. This was another mistake of Kite, where it tried to pronate the forefoot in relation to the hindfoot, and it locks the midfoot and does not allow further correction. So that's important to note. So the forefoot is normally is pronated, so you then supinate it as shown here to elevate the first ray. So, and do not pronate it as shown here. And that's how the first cast would look. You then move on to A and V, which is forefoot adduction and hindfoot varus. Here, using the calcaneopedal block principle we talked about earlier, and maintaining the foot in the same degree of supination that you already obtained in the first cast. And then you place the thumb on the lateral talar head as shown here, and then the other 2 fingers underneath the forefoot, and then you abduct the foot, correcting both forefoot adduction and hindfoot varus at the same time, using the kinematic coupling principle of the subtalar joint. And using a series of casts, as shown here, the foot goes from my left to my right. The hindfoot varus and forefoot adduction are corrected at the same time. And to some extent, the subtalar equinus is corrected. And when you see that the hindfoot varus is completely corrected and the forefoot adduction is corrected, the only remaining thing is the ankle equinus, that's when you know that the foot is ready for the Deenanath to correct ankle equinus. Also, you need to achieve maximum abduction by abducting the foot to about 60 degrees in relation to the thigh. One question the parents ask is this wrinkling. As you notice, as you start correcting this foot, you see this wrinkling that increases over the lateral part of the foot around the sinus tarsa area. The parents are kind of worried about it. So you have to tell them it's just the redundant skin, and it takes about 6 months to a year for that to resolve. And it's not something to worry about. Sometimes there may be some maceration there, but usually it's nothing to worry about. So this is how the correction happens. So some important points is localizing the talus. Sometimes in a stubby foot, it may be difficult to kind of localize the lateral talar head. So what you do is you overcorrect the deformity, which makes the talar head obvious, like so. So this is the fibula marked in red, and the talar head, lateral talar head is in green. So it's the first structure, anterior and distal to the fibula, okay, or to the lateral malleolus in this case. And then where to put the fingers, you put the lateral border of the thumb or the radial border of your thumb, of your right hand in this case, on the lateral talar head as shown here. The rest of the fingers can be, the index finger is behind the fibula, the other fingers are not doing anything, they are not blocking the calcaneus, and the other hand is as shown. This is Ponsati's hand, and here you show the same thing, molding. It's also important to keep the hand moving, not holding it in one position, because doing that causes indentation of the cast and can cause skin pressure. Also, what material you use for casting is important. Usually rapid setting gypsum is good, and you may want to use some lukewarm water, because if you use cold water, it takes a longer time for it to set. So you can control those things using that. In the infant foot, you can use a single-handed maneuver sometimes, as shown here, where you can use the thumb of the same hand on the lateral talar head and the fingers under the forefoot. You don't have to use a two-handed maneuver like so. That's called as a one-handed maneuver. And here, Ponsati's, you see Ponsati's index finger behind the calcaneus, showing he's molding it above the calcaneus so that cast doesn't slip. And the cast goes all the way to the groin, because in an infant, if you just go up to the below knee, it's likely to slip. So by flexing the knee, you prevent it from slipping, and also you get the external rotation force to correct the foot. As you can see, when the foot is abducted to 60 degrees or so, and the hindfoot valgus is corrected, forefoot reduction is corrected, and this is what is shown in the last cast on the right, then you're ready to do the Deenanath. Thank you. I'm ready for questions.
Thank you, Mohan. That was very good overview. We have a question from audience. Dr. Manish Prasad from AFMC Pune has a question for you and all the faculty. He's wondering whether we abduct the forefoot by exaggerating the equinus, then is it likely to give us quicker correction as compared to doing abduction in whatever position of equinus it is?
I think I don't know, I have not tried it personally, but if you put it in, so because the abduction and varus essentially are happening through the subtalar joint. So in my mind, I would say creating more equinus, would not change the kinematics of this, how the subtalar joint works. So I don't think that would add greatly in being able to abduct more or less, in my opinion. Thank you for the question.
Okay, anyone else? James, Alaric?
Yeah, may I say something about it?
Yes.
I think when you do the first part of the cavus correction, there will be an force which will also stretch or correct part of the equinus, which you can't help it. It has to happen. If you look at normal foot and ankle movements, it's not only about subtalar. Pronation also occurs at the, you can't pronate your foot in plantar flexion and supination. You understand? So it happens at the ankle as well. It's a combination movement between ankle and subtalar in normal kinematics. Supination and pronation, a combination of midfoot, subtalar, or the triple joint to the acetabulum pedis and the ankle. That is one. Two, the more equinus you keep the foot, the higher the chances that plaster is going to slip. There are enough of kids who are wrigglers, and when their thigh segment is like conical, they usually tend to slip. And you can't hyperflex too much to prevent it. So I think for those two reasons, probably Ponseti may not have put them in further equinus. I think that's what I would think.
Okay.
I hope it makes sense. I don't know.
Alaric, any comments?
No, I quite agree with what the previous two speakers have said. They have answered that perfectly correct. Thank you.
Thanks. Any more questions? Any comments? Okay, so we move on to the next.
Ashish, can I ask one question?
Yeah, sure.
Mohan, it was an excellent presentation. I have a question for the Mohan. What is, because there is no clear-cut guideline for the manipulation of foot before casting, and that is really subjective, because I know that in UK and many developing world, the physiotherapists were involved in the manipulation before they put the cast. Even in Israel, they put for the 15 minutes to 20 minutes for the manipulation before casting, and it's quite subjective. So what is your protocol for manipulation before putting cast?
Yeah, means it serves two purposes. The first purpose is you will get a sense of how much you can push that foot, so that you don't unnecessarily stress the soft tissues and create like any damage to the soft tissues. Second thing is, in addition to pushing it, you also are distracting. Like I said, with your fingers, you go all the way to the talonavicular joint, and then while you're manipulating, you also distract. You put a little bit of traction, and that allows, that prevents crushing of the talus as you bring the navicular around the talus, and the calcaneopedal block. So those are two things that Ponseti and Marquand stress. And usually the duration I do that is just for about a minute or so, not more than that usually. So I hope I answered your question.
Yeah, I agree with that. There is no doubt about the benefits of the manipulation, because I also do manipulate, but whether it is the uniform throughout the world, Dr. James?
Very interesting you say that. What about 21 years ago? Of course, I never went to Iowa, though I sent a plaster technician to visit Ponseti. But when I first did the course, the teaching was 90 seconds of manipulation at every time. Irrespective. So now whether 90 or 60 or 120 makes a difference, I'm not too sure. The question is, you're right. I don't know, you may be right that the physiotherapists may be doing it for longer time. If you look at the French technique, they of course do a little longer than, I think they almost do 15 to 20 minutes, and then they put their CPM and so on. So if you look at the French method, which goes on a totally different philosophy, and possibly they too have got reasonable results, but it's not practical for many a country to follow their method. So yes, I think, the other thing which maybe if I have to put a little spanner in the works is it the fast 5 week, instead of 1 week, doing a fast track protocol every 5 days, does it make a difference? Is the question. Why in the UK we follow every week is because that's how our clinics are set up. Our clinics are in such a way that it falls every other week, like mine was always on a Wednesday or Monday. So we don't want to swap, things. So I do not know is the question. But I suppose 90 seconds is what I was taught many, many years ago. And of course, my colleagues now do the Ponseti for the standard ones. I do for all the other, whatever syndromic stuff come to me. But yes, it's a good question though, yeah.
What is the practice in Alaric? Yeah, Mohan, continue, Mohan, sorry.
No, I just wanted to add that Markwende has a paper published on the rapid technique where, for patients coming out of town or out of country, they keep them there in Iowa and try to finish it in about 3 weeks or less, where they do the cast every 3 days. So I think the fastest they have gone is about 3 days with the casting changes, and then the longest is about 2 weeks in the older children.
If I may say something there, I think a lot of what we talk of the Ponseti method is a large amount of art and some amount of science. There's a lot of aspects of the Ponseti method which are difficult to prove at times, and maybe we may never have those answers to them. I think really we're not really watching that clock to see whether we are manipulating that foot for 30 seconds or a minute or 2 minutes as such. I don't think Ponseti ever stressed about that. All he said was manipulate the foot enough to take up that crimp which is there in the collagen, in the ligaments and in the tendons, and then you do it enough till you find what position the foot comes into now, and then cast the foot in that position, and then at a subsequent cast change, whether that's 5 weeks or 5 days or 7 days, you then move it a little more. So every time you get that little more correction. So yes, I agree. As James said, I visited the French method and I saw how they were doing it, and that's an extremely elaborate method of where the physiotherapists invest almost 20 to 25 to 30 minutes in manipulating the foot, because they believe the functional approach to the correction, and then sort of tie those feet up in skis or tape them with skis and make those children, if they're the older ones, to actually walk around in the clinic for some time. And they never use casts at that point, So there are two different philosophies. And I think if you follow the Ponseti philosophy, those few seconds of manipulation to get the desired position and then cast it in that particular position is what's recommended. Thank you.
Okay, thank you everyone. So if there are no questions, we will move on to the next presentation by Tim regarding management of neglected Clubfeet. Thank you.
Thank you. So this is returning back to an older child, and I just hope I'll be able to give you an insight into our journey in trying to discover and get evidence for treatment of these older children with Clubfeet. So our goal is to try and develop an evidence-based algorithm for these children in Ethiopia. So this was our go-to a number of years ago. So a posterior medial release, extensive deep surgery, and even in older children like this. I just got a follow-up video of one such child here, and I think you can appreciate that they're having difficulty in balancing. There's a wide gait, and clearly in feet like these, there's stiffness, there's deep scarring from the previous surgery, now presenting as a very significant challenge. Probably they'll never end up with a supple foot. And just looking at the data from that era of doing PMRs, it's at 46 feet, and we had 90% of persisting or recurrent deformity. And almost all of these children will be non-compliant with brace treatment. And so we decided moving forward, we would not rely on brace treatment to hold a deformity correction. We had a number of overcorrections as well. 3 of these feet had the classic overcorrection features of dorsal bunion, etc. One of the feet actually was very nearly amputated, as we lost a considerable amount of soft tissue. The question came to me is a partially corrected or a current clubfoot following treatment worse than an untreated foot? I just want to share these pictures here. It's a boy whose right foot has had treatment, and you can see that he's weight bearing on the lateral edge. So decided to put him through a barograph, and you can see here, this is the a more normal foot, right foot. You can see the pressures are low. There's heel strike and toe off. This is his pre-treatment clubfoot, and you can see there are high pressures, and the toes are barely touching the floor. And now you can see here, this is post-treatment with him in that supinated position where he's overloading the lateral ray. In fact, peak pressures are much higher than they were even before we started treatment. So I think the answer is definitely yes. An undercorrection can leave the patient worse off, even though they've got a smile on their face because their toes are pointing the right direction. Children would be in significant pain in an undercorrected position. So our treatment protocol changed in 2014, and here we have some data from the first 100 cases, and instead of a 90% failure rate, we almost had a 90% success rate. And we're now looking at the same patient group 5 years out. Most of the patients had a maximum of 9 outpatient casts, and after that we discontinued and classified them as having failed casting. They were then admitted for equinus correction. Obviously these are much older children. You couldn't do that easily in clinic, and so an equinus correction would be a percutaneous Achilles tendon lengthening, and then a tibialis anterior tendon transfer once we'd achieved our goal of 15 degrees dorsiflexion. There was no need for any daytime ankle foot orthosis, and those that were cast resistant after 9 casts underwent invasive surgery. So here we have a 6-year-old boy, idiopathic delayed presenting clubfoot. He's undergoing the manipulation and casting, and typically, following on from the discussion just before, the manipulation period is much longer. And we would aim to go for a 5-minute manipulation at an absolute minimum, and particularly trying to see if we can reduce things like pressure points that would create necrotic skin and other problems. So our casting protocol would be to go for cavus correcting casts until the cavus is fully corrected. This often means the cavus correcting casts, we may need 3, 4, or 5 of them until that is properly corrected. That deformity is particularly difficult to correct, and we've just been using casting for that. We haven't been doing plantar fascia releases or anything else like that. All our casts are long leg. This doesn't mean they go to the groin though. So long as they get as far as the mid thigh, we think that's okay. That seems to control rotation enough. Again, pressure point awareness, the knee is at 45. There is a problem with long-term casting and knee stiffness. So we reduced our knee flexion from 90, which we use for infants, to 45 degrees in these older children. And then the assessment of the foot is out of cast. What you think you see on the cast and when the cast is removed may be different things. Our criteria for surgery, this is the equinus correction surgery, is a sunken talus, a heel that's into valgus position, and a midfoot that's at least at neutral. So this is after 6 casts, and this child requires more. And after 8 casts, they were then ready for a percutaneous Achilles tendon lengthening, then a tibialis anterior tendon transfer, combined with an abductor hallucis release once the full 15 degrees of dorsiflexion had been reached. So this is the lad post-op. So classically, they would need to undergo a fair bit of rehabilitation. And this is at 1 year following surgery. Here's a second case. The left side is obviously much more affected, and a slightly older child. And again, his post-op, in this case, he's running around. Just to show you, he's painless and plantigrade. And what we tend to find out with these kids is that they do tend to have weakness in the calf muscles. So going up onto tiptoes sometimes can be difficult. This guy, I think, can manage that just about. Certainly going up onto tiptoes on one foot is usually very difficult. But as with all club feet, it's the ankle, quality of the ankle, which is important, and dorsiflexion, which gives him such good function. So the limited surgery, which is for equinus correction, is usually a percutaneous Achilles tendon lengthening involving a 3-step procedure, such as the Hoke procedure. And for those under the age of 5, perhaps a simple tenotomy is all that's needed. We don't do ankle capsulotomies anymore. We will perform a cast wedge or further casting following this, because that will enable us to further stretch the posterior ankle structures, such as the joint capsule. And then the tibialis anterior tendon transfer is performed in the vast majority of patients. And this, we think of the concept of it being like a biological brace, and is taken to the lateral cuneiform under full tension, secured by 0 vicryl over a button. So this is just a short series of photos showing our cast wedge procedure. So we've done the Achilles tendon release, and now we're going to take out a wedge of cast and then apply further plaster of Paris. It's quite a controlled way of correcting further equinus and checking the toes for perfusion afterwards, obviously. So of those that are not corrected under the age of 10, I would say these were somewhat more unusual cases in our setting. We need to check whether the percutaneous Achilles tendon lengthening was indeed complete. And as I mentioned before, getting a nice cross-table lateral X-ray to look at the talus morphology, I think, is important. Rehab is certainly important. I just want to draw to your attention a few things here. Check out the hyperextension at the knee joint in this kid that's never been treated. Have a look at the pelvis, which is thrown forward in flexion, and that's causing a lumbar lordosis and kind of protrusion of the belly. So what we tend to find with these kids is there's weakness, and it's not just in the below the knee. There certainly is weakness below the knee, but it extends above the knee. Some of these core muscles are very weak indeed. Abdominal muscles are very weak indeed. The hamstrings are often functionally long, and certainly we've seen that in our gait analysis of these patients. So exercise classes, during and after, we consider to be an important part of rehabilitation and will help these kids to get on the road to recovery faster. So the questions that need answering from this is, how does casting work in the older child? Is it just through ligament, tendon stretching, soft tissue, or is there cartilage plasticity going on? And if so, does that affect the duration and the timing of the changing of casts? And I think an MRI study is needed to determine this. Secondly, it raises a question of what is the best outcome measurement tool for these children? Is it a patient-related outcome measure, or is it an observational functional performance score? And thirdly, what to do with those that fail casting? So just to talk about that for a brief moment, we do see cast resistance, and the common bony deformities that cause that are the classic flat top talus, obliquity of the calcaneal cuboid joint, and sometimes the cuboid does resemble more of a triboid than a cuboid. And you can see the sort of like the thumb finger process of the calcaneum probably is never going to reduce in these cases. And thirdly, and has been previously mentioned, the navicular is somewhat wedge-shaped. And so the further correction you get, the more difficult it is. So we looked at 55 feet that failed casting up to the age of 14 years and randomly allocated them to either a soft tissue distraction procedure, as you can see top right, and that was followed by a tibialis anterior tendon transfer, or a stage triple arthrodesis, as you can see being performed on the bottom right. The outcome measures we used were the Laveg and Ponseti outcome score, and we looked at which of these treatment arms required additional surgical interventions as well. So in terms of the recurrence, we had 9 patients in the triple arthrodesis group that required additional procedures. Some of those were additional frames, some of them were additional triple arthrodeses, other things as well, some midfoot osteotomies. And that's to compare against one patient, 1 foot, in the soft tissue distraction group using the Elizarov apparatus. And you can see on the right here the outcome measures and scores using the Lavag and Ponseti outcome measure for the 2 groups. And there's a significant and obvious benefit in the Elizarov soft tissue distraction group. And this actually, when we looked at subgroup analysis, it was even more so in the younger age group. So those around the age of 8 or 9, Elizarov soft tissue distraction patients did very well, and moderately well in the older group as well. But the triple arthrodesis patients had a widespread, but generally they didn't function as well on the scoring. Here you can see this right foot. You can just tell that he's trying to stand up, and I've got my fingers underneath his heel, and getting the equinus correction, even after significant amount of casting and attempts, getting equinus correction with a triple arthrodesis is very challenging. Often you're pushing, and what you create is a midfoot, essentially a midfoot break, and you have the most anterior part of the calcaneum is prominent in the sole of the foot, which is very unsatisfactory. So in the mature feet, girls over the age of 12, boys over the age of 14, neglected clubfoot becomes a very, very difficult prospect, and some of these feet are very challenging. Our protocol has been either to leave them alone, and clearly if a child is not in any pain and an adolescent is not in any pain and he wants to do a physical job, that may in fact be the right way to go. For many, they come to our services asking for correction, and if the deformity is mild, we would consider a triple arthrodesis. Possibly if the calcaneum is high riding, we would do that in stages and do a first stage soft tissue release and then a triple arthrodesis. I have tried doing V and Y osteotomies on these types of patients, and correction is achieved, but that is a very, very long duration of correction. And in my experience is that in treating like 2 or 3 of these cases with this type of treatment, it's very painful, and patients really are suffering. You can imagine the amount of distraction that's occurring on the medial side of this foot if you're going to just do osteotomies and correction. So lastly, we've been looking at doing triple arthrodesis and combining that with a frame. So essentially to do modest cuts for a triple arthrodesis, applying an Elizarov fixator frame, and then getting correction of the residual deformity in a slow fashion, which seems to be better for soft tissues. And classically, we push those into a slightly overcorrected position, leave them for a while before removal of the frame. Gratifyingly, we've had better results with the adolescents with Clubfoot with this technique. Thank you for listening.
Thank you. That was excellent. We have a few questions from the audience. Dr. Jasbir Singh from Himachal Pradesh has asked for rigid idiopathic clubfoot with severe equinus. Is there any role of early tenotomy? So what are the recommendations of the faculty? He's specifically asking about idiopathic clubfoot.
I'm sorry, just to restate the question, was the question about the tenotomy?
In idiopathic severe clubfoot with equinus.
Yes. So I think the answer is yeah. We do tend to do tenotomies, Achilles tenotomies for all of these kids. If they undergo a triple arthrodesis, we do it. If they're undergoing a Elizarov soft tissue distraction, we do it. So all of them have an Achilles tenotomy. The tenotomy versus, I think maybe the question was tenotomy versus lengthening. Would that be fair? So tenotomy for 5s and under, and lengthening for over 5s is my preference. Although I do understand that there are a number of studies now coming out to show that tenotomy in the older age group is effective as well.
Yeah. I had some questions, Tim. Thank you for the nice talk. This is Mohan, Belthur. One was, what do you mean by a sunken tail, like talus? Can you explain what you mean by that, please?
Yeah, I'll try. So obviously these deformities are assessed at every time that the cast is removed, and you feel that the prominent talar head laterally, and then within a cast or two, it's no longer there, and that's what I would call a sunken talar head. Now, I think that could be somewhat subjective, and I think that the casting practitioners they usually come and tell me when they've noticed that it's no longer prominent, and the patient is then ready. Of those cases where the talar head is still prominent, I will sometimes get an X-ray of those in a stress position under fluoro to check, because the navicular morphology sometimes and the talus morphology sometimes is quite abnormal. And what you think that when you think that the talus head has not gone in fact, when you actually look at it carefully under image, it indeed has, and it looks very satisfactory. So yeah. However, so for those cases that fail casting, I would tend to X-ray to look for that.
Thank you. So another question was about your stretch casting, where you wedge the cast.
Yes.
How many weeks after your tendon Achilles lengthening with the Hoke method you start in the older child?
Yeah. So for the cast wedge, I'd do that 4 to 5 days afterwards. I noticed that less than that, it's not enough time. More than that, I don't believe there's any point in waiting around. So I tend to go with something like a 4 to 5 day interval between the tenotomy or lengthening procedure, percutaneous lengthening procedure of the Achilles, and a cast wedge. If you were to do it with serial casting, I think probably weekly cast would be very satisfactory.
Thank you. And then one more question. Can the Ponseti method be used after the age of 10 years for neglected club feet? Because I think some of us and other people I've heard have used it even up to the age of 40, and sometimes it could work.
Yeah. So in my group, I was looking at, again, idiopathic delay presenting clubfoot rather than, say, neuromuscular or neurological spastic feet. So I would say definitely yes. And of course, you will get cases that will fully respond. And I think all patients should have a trial of Ponseti manipulation and casting. But I think the expectation is that the vast majority of them will not respond. And that is due to, it being more of a bony foot rather than a cartilage foot in these adolescents.
Thank you.
We have a question from audience that would you do tenotomy after the second cast, then continue with casting and then repeat that?
Yeah, so I know that there was a paper published from India that did exactly that. So an early soft tissue releases and then casting. Personally, I have been trying to follow the Ponseti principles of getting the cavus corrected first, and then rotation around the talar head, and then the equinus in that sequence. And it seems to work for my population here in Ethiopia.
Thank you. Alaric, any comments, anything you want to add?
So I'd just like to amplify some of the things that Tim has elucidated so well with his talk. I think a couple of comments first is that we tend not to use the term neglected now because that has a bit of a negative connotation and it's a little disrespectful. You know, when you say neglect, does it come because the parent? Does it become, is it because of society? So I think the better term is what Tim Nunn alludes to and says, late presenting clubfoot or delayed presenting clubfoot, I think is more appropriate rather than using the term neglect. And that's one thing that probably should move out from our lexicon. The second thing I would say is rather than using the term Ponseti method for the older child or for the late presenting clubfoot, it'd be better to say manipulation and casting using Ponseti principles, because there are some deviations from what Ponseti originally described for the younger child. So just a few sort of changes in terminology is what I would tend to use. I agree with many of the points that Tim brought up with his presentation. There are some little deviations that we follow in India where we have a significant number of these older children or late presenting club feet as well. I'll just highlight some of those differences if I'm permitted to. Is that okay, Ashish?
Please, yes, please.
Sure. So one is that I think we have a little higher threshold for the number of casts. I think Tim puts a number saying 9 casts, whereas we have the times gone up to even 15 or 17 plasters. And what we use is that if we see the foot is correcting with every plaster change, we are quite open to using casts which even go beyond 10 or so. And the clinical tests that we tend to use, which are the children who will sort of benefit or likely to fail from the Ponseti principles, I think I would point everyone to this very seminal paper that was published by Norgrove Penny in 1995, which was titled The Neglected Clubfoot. And in that, he talks of these 2 types of these older children. And I found that to be very useful in clinical practice. Not many people have highlighted that point later on. But we are looking in terms of that. You have, and that's irrespective of age. You find there are 2 types of feet of these older children. One in which the child walks on the lateral board of the foot, where the plantaris of the cavus is not very much. And these are the feet that look bad when the child stands, but when you put the child supine or non-weight bearing, you find that the foot actually is quite flexible. And these are the feet which tend to correct quite well, and they score higher, score lower on the favor score, and tend to respond quite well to the Ponseti principles. Whereas there are a group of children who have really rigid cavus and plantaris, and who almost walk on the dorsum of the foot on the talus. And for lack of any better terminology, I would say, like it's called the penny 1 and the penny 2. And the ones who have the penny 2, which are far more rigid, who tend to walk on the dorsum of the foot, are the ones who are more likely to fail the Ponseti principles and need more extensive surgery. So we have used that, for lack of any better terminology, as a prognostic indicator, which are the children who are likely to benefit using the Ponseti principles. The other points that Tim has brought about flexing the knee to 45 degrees, we agree with. We are a little more, we tend to use the plantar fasciotic for cavus correction in these penny type 2 feet, where we have a very rigid cavus and plantaris. We feel casting them sometimes wastes a whole lot of time. And if within a couple of plasters we're not able to open up that cavus and plantaris, we don't hesitate doing a percutaneous plantar fascia release. We find that really helps to save a couple of plasters rather than wasting our time working on the cavus correction, which is working a really short lever arm at times, and it's very difficult to correct in these type 2 feet. The third difference is that we use percutaneous tenotomy routinely in all children up to the age of 10, and we've even gone to children who are older. There's lack of scientific evidence to know what really happens with these feet, and we have now begun a prospective study to do an ultrasound of these children, where we're doing a percutaneous tenotomy to see the healing sequentially over time, and match that the clinical findings of toe raising and toe walking to find out whether there are any deleterious effects of complete sectioning of the tendo-achilles, even in children who are much older. Clinically, we have found that does not happen, but we have never proven that. So I think that's an important study, and if anyone likes to collaborate on that, that would be wonderful, to actually prove that you can extend your indication for a complete tenotomy to a much older age, because we have found that the minute you take an incision over the tendo-achilles, and if you violate the joints, you're likely to have more stiffness than anything else. So with this tenotomy in the older child, we find that it's impossible to get the 15 degrees of dorsiflexion that we desire using Ponseti principles. And almost all of these children will need either the cast wedging, what Tim Nunn does, whereas we prefer to do sequential or serial casting for 2 or 3 sessions every week. And we find that this extended casting helps us to get that dorsiflexion of at least 15 degrees. I don't think we can achieve more than that in these older children. I think that's a reasonable outcome to get a plantigrade foot going up to about 15 degrees of dorsiflexion, which will allow you to clear your foot during the swing phase. So those are a few other differences in our practice compared to what Tim highlighted. Thank you.
Yeah, can I just respond briefly to that? I think we're talking about the same thing with the penny type 2. So I would actually have called them atypical club feet, and I agree with you that they require a different strategy. And certainly the those plantar fascias are very tight, and with the profound cavus and profound plantaris, I'm sure that's the right way to go. Thank you.
Thank you. I'm sure we'll have more questions, but because of lack of time, we move on to some cases, and I request Hitesh to proceed with the case discussion. Thank you.
Yeah, thank you, Ashish. I think we'll move on the first case directly. I'll ask Viraj to present his case first. Viraj, you can unmute yourself.
Yeah.
Yeah, okay.
Are you able to see my screen?
No, not yet.
Ashok?
No.
Yeah, I clicked on the share, but I'm not able to still. Ashok?
Yeah, click on the share button, sir.
Yeah, I clicked on it.
Window opens. You can find your presentation there.
Yeah.
You click on the presentation, click share. Now come back to the Zoom panel, sir.
Yeah.
Click on the green share screen tab.
What am I clicking?
There is a window opening. Once you click the green tab, what happens? Okay. Yeah, we can see that now.
Yeah. Sorry for that delay due to technical difficulties. So, I think 10 minutes has been given to me, Ashish.
Yeah, please.
Yeah. So, there are a couple of interesting cases I would like to just, as we discussed in the last talk by Dr. Team, that this is now an 8-year male child who has delayed presenting idiopathic clubfoot, or what you can call as a neglected clubfoot. And he wants to go a single stage treatment, because many of these children, we select them in camps and then they come for the treatment, and they are not affording to stay longer, and they are not willing for repetitive casting. So, Dr. Team, what would be your approach in this case? 8-year child, idiopathic clubfoot, want a single stage treatment.
I'm sorry. Did I hear you right that he wanted a single stage treatment?
Yeah, single stage. He don't want to go ahead for the multiple casting, and then he want the foot treated because there are a lot of issues, social issues which are involved. So,
I think the other panel members would be best to comment, because for me the posterior medial releases and other things, the outcomes are so poor that I wouldn't offer that. So I would highly recommend that he goes away and finds someone who can stay with him, sort out social issues.
Okay. What about James, Dr. James?
I mean, I do come to India and do some work in St. John's, Bangalore. These are all difficult situations. There is no right or wrong answer. I mean, patients' expectations are different, and they might, for social reasons, want. So when I come, we actually, I don't know, sometimes is it because they can't afford the treatment, or is it because...
Most other times.
Okay, so...
Yeah.
I mean,
but suppose this patient is affording, Dr. James, suppose the patient is affording, then and he want to go for a single stage treatment, what you would offer?
Then I would refuse to say that from my experience, unfortunately, the results are not good. And if they can afford, then they should be able to understand, I think. I think that's what I would do. Yeah.
Okay. What about Dr. Mohan? What will be your approach from US? So now we have heard from Ethiopia and UK.
I would spend more time with the family trying to educate them and understand why they are refusing the treatment, because sometimes getting into the nitty-gritty of why do they want first stage treatment, and telling them also about the long-term results, that a short-term treatment, one stage treatment, though may look attractive and less investment of time at this point, but does not provide good long-term results. So would they want a foot? Would they want their child to have a foot which works his whole life, or which works only for 2 to 3 years of his life? I think if you ask those questions to them and involve them and provide them enough information, I think they will come around.
So
I think that would be the right
suppose
thing
they
to do.
agreed with you, Mohan, suppose they agree with you, then what will be your treatment in this child, 8-year child?
Yeah, I would do pansody casting, same thing like what Tim discussed.
So from that, we'll come to our own colleagues from India. Atul, any different opinion you have from Mohan, or you would like to do some surgery? Atul is there?
Yes, Viraj, can you hear me?
Yeah.
So I would certainly, go with the lines of counseling them first and try and correcting as much deformity using the Ponseti principles, as already alluded to, and do less surgery if I can. I can understand the dilemma, because many of the children, they want single shot surgery, and I have done that in my practice as well. When they come, I've gone ahead and straight away done a surgery. I've done, in fact, Cincinnati release with bony osteotomies, and they tend to look good. They get corrected very well. They get stiff as well. But you get a planted foot. So I can take a dilemma, because coming from the same background, we face this often where, despite counseling, they would go to somebody else who would then do an incorrect surgery, or put a fixator without any knowledge, and then and I've seen these feet coming back with problems, with recurrence and a more difficult, challenging issues. So if they come to me, if despite my counseling, if they're not going to really, stay longer, then I would not hesitate doing a surgery, to be honest.
Any different opinion, Hitesh? Hitesh from Manipal now. We'll move to different part of India now.
Yeah,
Hitesh?
actually, yeah, I can. Can you hear?
Yeah.
Yeah, I agree with all the panelists that we need to spend the time with the family for the advantage of the manipulation and casting. And at least manipulation will not correct completely, but it will decrease the severity of the deformity. And once patient will be convinced, what I generally do in my practice, let us try for 2, and once they see it's getting corrected, they will get convinced very well.
Yeah, from Pune, Ranjit. Ranjit, would you have the same approach as Hitesh has described?
Yes, even I would consider casting initially, because it tends to reduce the number of surgeries that you need to do later.
Right. Okay. Any difference, Ashish? Ashish?
I agree. I agree with the rest. I will try to discuss with them.
Okay. So our approach is same, that for those I am talking about Deshmukh one or two deformities or the flexible variety, we still go ahead with the Ponseti correction, casting, and then mini-invasive procedure. But for those who are rigid, we go ahead for the, I will just briefly go a little faster. So because we do get a lot of this kind of neglected or the delayed presentation or the recurrent feet where people are operated and 2, 3, or maybe 4 surgeries has been performed. And our consent are, we have most of them, they come from the low socioeconomic background, limited resources, long-term hospitalization is not possible, and they want a single stage procedure. I'm talking about the rigid variety. I'm talking about the grade 3 or 4 cases. So this is a kind of a middle path we have devised, where we do the plantar fasciotomy for the correction of the cavus, rather than asking to come for the 4 or 5 casting required for the correction of the cavus. We do the so everything is done at the same stage. We do the plantar fasciotomy to correct the cavus, and then the percutaneous tendoachilles stenotomy, which will correct the equinus and to great extent varus as well. And then we do the single stage dorsolateral closed edge osteotomy, right? Now this is a picture how we do this. The tenotomy is complete tenotomy. With I mean, we have operated even till 40 years of the age, what Alaric was discussing, and we didn't find it the tendon regenerate very well. Plantar fasciotomy, and then a dorsal edge osteotomy where we just take the elliptical incision and we take out the wedge from the cuboid, the lateral, medial, and intermediate cuneiform, and depending upon the severity, we might expand or extend this osteotomy to the further bones. Then we take out the wedge and then close the osteotomy site. It just like we are closing the open book. And when we stabilize the forefoot to the hind foot with the help of the KYS like this, and we use a graft which has been removed from the wedge, the same type, so that we should not have any kind of non-union. And then we put the drain which has been removed and water hematoma which is there on the third day from a window which is there. And then patient is discharged on the fourth day and is called as 6 week. We took out the wires and then they have to use a simple AFO. And then the special consideration where if equinus, if you find on table is not correctable, particularly the orthorhaptic fit like that or syndromic fit, where we might extend the incision, the posterior incision to some extent, and we actually release the capsule from the same incision, and that gives the outcome. We extensively studied this procedure, morphological, functional, and radiological evaluation, and we found that it was effective, usually in relapse as well as the neglected clubfoot. So this is a gait you can see, the pre and the post-op. Now the beauty of this procedure is we are not touching the talus, as compared to the triple orthodosis. We are preserving the talus and the subtalar joint. And because of that, you can see the mobility. The foot is very good. It is mobile, right? So we have the hopping, and then this is you can see the squatting and dorsiflexion. And we have very long-term follow-up of these cases. So this is another example of recurrent deformity where this child is a 9-year-old. He has been operated 4 times elsewhere, and as Dr. Team was mentioning, they have a secondary effect as at the knee and all other areas. So they have, and this with the same procedure. This is a 4-year follow-up, and this is a 9-year follow-up. Most of the children we have a follow-up of almost till maturity, many of them. So this is not a normal fit, I will not say, but this is quite a plantigrade fit. This is another example of the same technique. This child has come from Nigeria. He has undergone almost 6 surgeries in the past, including the posterior release, ILLRS and all, and the very, very rigid and stiff fit. So these are the cases where we need to extend, we can extend our wedge to little more area. Sometimes, if very rarely required, we can extend up to the metatarsal as well. And this is correction we got for the first feet, and then subsequently came for the other feet, just like that. We extended this, our indication, to the neurogenic foot as well, as where we can, from the same osteotomy side, we can take out the necrotic bone. And then this is a 5-year and 7-year follow-up of many of this patient, and even we have more than follow-up for this. The comment about the a case which was Alaric was discussing, when we started with the extended paucity indication, I'm talking about 2004 or 2005, where there was a lot of boom about the extended paucity. For this is a 3-year child who was walking with almost on the dorsum of the foot. If you see how she's walking completely on the dorsum. That is what Alaric was telling. So we could get the initial correction. We got a correction by severe plasters and tenotomy, and this was the correction what we got. In spite of good splintage protocol and then the follow-up, as she started getting recurrences, and then subsequently deformities increased. For the 1 feet, we had to go ahead for the rotational osteotomy as well, in addition to the dorsal cage osteotomy of the foot. And this is for the other feet also we operated. And this is a correction, and this is a 3-year follow-up of the same girl. And then subsequently we kept her under follow-up. You can see the plantigrade foot with it's basically the good mobile foot. The mobility of it is a 5-year follow-up of the same girl, and this is 12-year follow-up. So most of the children we have our long-term follow-up of 12 years, 14 and 15 years, many of them without, none of the child has any kind of arthritis, and see the functional aspect of that. So it is a beauty of this. So I personally feel that we should not, stick to some fixed protocol or like that, but we should consider the different options which are available. So it is very, less expensive. I will not say as compared to ILLRS and other methods which are there. Not any kind of any neurovascular problem. We had no wound problems because we are not touching on the medial aspect, and rather by taking out the wedge, we are preventing the tension on the medial aspect. I agree that there is some chance of shortening of it maybe, but even if you see the long-term follow of the positive series, there is a shortening of 2 to 3 centimeter in most of the series. So in summary, I think this is one of the good procedure where we can consider, for the most of the cases, particularly in our Indian scenario, where they come and they ask for the single time procedure. Again, I'm saying I'm a strong follower of Ponseti, and I do use Ponseti for most of the cases, but these are the situations where we should consider the dorsal closure osteotomy. It is one of the beautiful thing to work. Over to Hitesh. Any comment, Hitesh, and all faculty which are there?
Thank you, Viraj, for your good follow-up, good correction, and maintenance of the correction in follow-up. I'll ask Dr. James, what will you do for the older case actually in your protocol, do you see untreated case in UK?
Extremely rare.
Okay.
I used to see asylum seekers some time ago. We don't see that now anymore. There are, but it's very rare. The odd one from UK, which are, I shouldn't be using the word gypsies. They move place to place, and then they're not compliant with Ponseti even after 2 or 3 trials. So the numbers are very few. Just to go back to what Dr. Shingade said, we also went through all this many, many years ago. I used to do the same, all those procedures. But expectations in different countries are different. You have to remember. We are in the colder parts of the world at the moment, and they all have to wear shoes and socks. So the biggest, when you talk about PROMs and functional outcomes, you have to look at many other aspects when you look at. And we have just done a recent study of using the Roy score, and most of the complaints from a parent, which I'll say next week, is on shoe fitting. So it's very interesting how, and also we know from open surgery, there are papers saying that, by 40 years, 60 to 70% of them are in pain already and significantly stiff. So yes, your early results may be good, but the question is longevity. And it's like horses for courses, isn't it? So in India, it's a different expectation. So using the ASK score from Canada may not be the right score for India, but using the PAVR score possibly is more relevant for India than anything else. So we all have to, I know there are no rigid protocols here. At the end of the day, your patient and you have to decide what is best for you in your scenario, in your culture. That's what I would say. Yeah.
I agree with you, Dr. James. The philosophy is right. When I'm talking about older children, when you give the casting and when you try to forcefully correct in the cast, ultimately it is not a cartilage what Ponseti principle has described, isn't it? For I'm talking about 12, for 13 or 14-year child.
Yeah,
so rather than cramping the foot with or the bones with the cast, why not to do the osteotomy at that is the principle. When you're not touching the talus. If you touch the talus, if you are invading the subtalar joint, then it is fine. Then I can accept the arthritis and all other things. But if you're not touching the subtalar joint, I think these are they function very well.
For you, the issue is they want a single stage. For me, for a similar patient who would have been multiply operated, I will use a frame and I'll do through osteotomy technique. So at the end result is the same. We are trying to get a plantigrade foot, but by 2 different methods. That's all. Yeah, I think that's the difference. Because your needs of your patient are different to needs of a welfare state of mind in the UK. Or even when I come to India, I change my philosophy. I don't think like I'm here. So you have to realize it is again horses for courses. Yeah.
Yeah.
Any comment, Dr. Team? Dr. Team, any comment?
I just I would just emphasize really a point that of all those patients you showed, of course, with excellent function, the ankle joint is perhaps the key here, and having a really good ankle joint with good motors around the ankle joint is clearly something that you've got on those patients. I do try to avoid going in and doing osteotomies on like 8-9-year-olds, just because I tend to find that it's mostly cartilage that I'm going through, not bone, which I don't know, innately to me feels like I'm doing the wrong thing, but clearly you've got some outstanding results there. Thank you for sharing.
Yeah, thank you, Viraj. Now it is already time is 2 hours. Ashish, would you quickly present your case?
Yeah. So actually, I'm presenting on behalf of Dr. Nikhil. He was supposed to present, but he could not join. So it's a 9-year-old untreated Clubfeet. I think as Alaric was mentioning, type 2. So what he did was, Nikhil did serial casting in OPD. He had 6 casts, and then he did a posteromedial soft tissue release via the hemi-Cincinnati incision. And that's the result. Got plantigrade foot, that's the X-ray. And that's how he was. So just another way to treat this difficult problem. That's his function. Thank you.
Thank you, Ashish. We have any question, comments? I think we have discussed the last half an hour for the untreated clubfoot in the older child. So I think we can conclude and stop it here at 9.
Yeah. Just trying to.
Over to you, Ashish. Yeah.
Can I ask Dr. Tim? Dr. Tim, it's excellent work you're doing. So it will be very helpful for us if you have good articles on your PAVAS score system, because we can use for our neglected cases, So it will be very good if you could have some original articles you could share with us. Thank you.
He's published it in Strategies in Trauma and Limb Reconstruction. It is free access journal.
Okay.
Yeah.
What do you say, Dr. James? Strategies? Strategies
in Trauma and Limb Reconstruction. Is that correct, Tim?
Yeah, that's right.
That's what I read it.
The video which accompanies that is in the process of being updated. But yeah,
Can I ask a question? Ashish?
Yeah, please. Atul, please.
Yeah, Tim, just a quick question. You've been working exclusively with Clubfoot in the Cure Clinic, isn't it? Are you doing other pediatric orthopedic stuff as well?
Well, the patients that we see are very, majority, in fact, are Clubfoot cases. I do other things as well. Yeah.
So I just want to ask you, what's the compliance with bracing like? In the initial treatment. So when you get a child at infancy, you've done the Ponseti, the feet are looking beautiful, and you've got a dedicated team of social workers and a dedicated Clubfoot clinic versus somebody who like us who do private practice. We have a public practice as well, where we've got children coming in and out, but there's no dedicated follow-up apart from counseling the parents. So I think Alaric used to run a Cure clinic as well. So what's the compliance like? If you can ask James as well in the UK, if I can ask you for primary Clubfoot treatment. In terms of brace failure, what's the brace failure rate?
I assume you're asking about I'm sorry, the Dennis Brown boots and bar.
Correct, yeah. What's your kind of compliance in terms of percentage?
Yeah. So for Ethiopia, I think it's very poor. I don't think there's I don't think there's figures out there that I can quote you actually. But certainly there's issues surrounding not just compliance, but quality production as well, which also impact on that. So yeah, but I think it's very limited. I mean, past a couple of braces, we certainly wouldn't see many patients that have had 4 years.
Atul, yeah, I think about failure rate, I think there are two aspects, I think. One is, of course, true non-compliance from the parents. Second is possibly a suboptimal treatment. Sometimes you may not appreciate the suboptimal treatment or endpoint, and then you go ahead and brace. So in my own practice, which I audited many years ago, I would think I had about 15 to 20% of compliance issues. But this was the study done from I used to do a peripheral clinic in Barnsley. Now, Barnsley population is completely different. Similarly, Aldehay published their paper, and I think theirs was about 25 to 30% non-compliance. And we did a very small study, which was very small. We didn't have the numbers, by putting a few transducers inside the boots and bar. And it's quite interesting to note that many of these are actually either the heels are not sitting on it or they're not wearing it. It's like Shanmuga Sundaram's spinal braces for TB, MRC publication. How many of those kids really stood inside their brace? They used to slip out and go and play outside, and their parents were out. So it's a similar thing. I think Iowa group is a very different group. I think patients there are totally different. It's a population which does not move anywhere. Their scoliosis results are phenomenal because they don't go anywhere. For them, I don't know whether they know where New York is. So it's I think that's the way you have to look at it. Yeah, failure rate is quite easy for us as doctors or surgeons. Blame the patient. Actually, there would be some part of it is part of us itself, where we have not accepted. I think most of you will agree on that. Yeah. And we don't get it right all the time. You have to be. Even I don't get right all the time. So all of us are the same, I'm sure. Yeah. Apart from who gets 100% results for everything, I don't think the rest of us do.
Yeah, I think bracing is one of those unanswered questions when it comes to clubfoot treatment, and that's something again that has intrigued us a lot for several years now. And again, when you're looking at adherence to bracing, what are you actually measuring? Because you're asking parents how many hours are they actually putting the brace, and the presumption is that parents are going to be answering honestly. And it depends who's asking that question. So in countries like India, I'm sure many parents would say, oh yes, they're using it for the prescribed number of hours, and actually using it for maybe a couple of hours or maybe not at all in the day. So I think the only reliable way to do that is by installing sensors within the brace. And there have been a few papers which have come out in the last few years which have shown that the bracing compliance, or the adherence to bracing as we call it, is far lower measured by the brace, by the sensors, than what parents actually recommend to the parents. And the other question, of course, is how many years of bracing do we need? How many hours of bracing do we need in a day? And those are all unanswered questions. And as far as I'm aware, there's a prospective study called FAB24, which is being led by Matt Dog, which is looking into two different protocols, looking at using it for 2 years versus using it for 4 years. And I think they'll be ready to analyze their results and publish them, because it was a 4-year prospective study that they had undertaken. But whatever the papers came out from the sensors, there have been 3 papers so far, showed that if you use the brace for at least 8 hours for at least 2 years, it was sufficient. And that's the paper which has come out from Morgenstein and subsequently from other centers as well. And we recently developed a prototype for putting sensors within a brace, trying to get low-cost sensors which we can use in low middle-income countries, because I think it's the only way to determine objectively whether patients are actually using the braces or not. So I think these are questions which will be answered over the next few years. There's, as we said, so much of still art rather than science within the Ponseti method. And with more objective data, I'm sure we could be able to answer those questions over time. Thank you.
Thank you. Yes, next Sunday we will have a talk on bracing, and I'm sure all of us will have more questions. Before we end, I have one question for Tim. You showed that beautiful video of a child developing hyperextension at the knee. So after treatment, what happens? What's your experience? It goes away, or?
Yeah, I think it does. And if you've got a good ankle joint, then that corrects. If they're able to get into dorsiflexion well, that corrects. And you don't see the hyperextension, and they lose that. I think my point was that the rehab of these patients can be sped along by some focused training on particularly core muscles. So that was I think the hyperextension that you see actually will get better by itself, providing the ankle has got a good range. Thank you.
Thank you.
Ashish, can I add something to
Yes,
him?
yes, please.
Very interesting, because as soon as he showed the video, even our patients, after we do any frame surgery, especially bilateral, they all walk funny and they do all kind of funny walks. So actually they lose core stability, exactly what Tim said. And our physios actually work on core stability throughout. And it takes about a year before they actually walk properly. So that I think it's to some extent driven from the ankle, but quite a lot is loss of core stability and muscle strength in and around the hip muscles.
Okay, thank you. Yeah, I think there was one question from the audience. Any tips to make the cast stay longer and prevent slippage? Dr. Rao has asked this question.
Maybe for Mohan then. Is Mohan there?
Not there. I could answer that.
No, you can answer.
So, sure. So I think if you're talking of the younger or the older one, the older child, of course, it's challenging. But the advantage in the older child is that they're not as chubby as those younger babies are. So in fact, the chance of cast slippage is more in the younger age group I've seen, where you have these very chubby kids in whom the cast is so chubby that it's difficult to really get the plaster on well. So in the younger age, what we tend to do is use a stripe of tincture benzoin, and we find that helps to hold the soft roll and the cast onto the skin. So that's something that I tend to do. The other thing, of course, is to bend the knee to 90 degrees or sometimes even a little more in these very chubby children, almost treated like an atypical or a complex Clubfoot, where we need to bend the knee more than 90 degrees in these younger children who are quite chubby. And the third, of course, is there's no question that a well-fitting cast and a well-molded cast is the best way to avoid cast slippage. I think if you follow these three principles in a younger child, there should not be a problem at all. The older one, as we said, they're less chubby, so the chance of slipping is less. The only reason there when they slip is because of the severe equinus, and hence we don't use below knee casts in these older children. I know there are several people who treat older children who believe in only using below knee plasters, and we don't do that. We use above knee plasters for even the older child, even if they are 10 and above, for the simple reason that the equinus can be quite severe, and that causes the cast to slip off if you give a below knee cast. So we invariably use an above knee plaster, flex the knee to 45 degrees or less, and we find that really helps in the older child. Anything you would like to add, Mohan, to that? Sorry, I answered the question on your behalf.
No, that's fine. Thank you. No, I agree with the points you made. I think the key is when you do the cast padding, it has to be really conforming, very little space, as tight as possible. Pansati keeps, like Markand tells me that every time, like Pansati used to keep telling him, even though he has spent so many years with him, tighter, he used to sit in the corner and tell him the cast padding should be as tight as possible. So there should be no space. That's one thing. Secondly, spend more time holding, really, like above the calcaneus, around the malleoli, etc. So there is very little space there. And then the other things you already mentioned, the tincture benzoin, bending the knee to 90 or even more, 100. And also another thing I would like to add is quadrilateral molding of the thigh segment. And in the more late presenting and syndromic kids, like quadrilateral molding of the thigh segment rather than a cylinder, will help prevent slippage further. And then cast extends all the way to the groin. If you stop just above the knee, rather than going all the way to the groin, again, they can slip out. So those are some things I would say.
Okay, thank you. Well, if there are no questions, then I think we end this webinar today. Thank you for joining us, and I would like to thank all the faculty for sharing their expertise and tips and tricks. And next Sunday, we'll have another exciting session. We'll be talking about external fixators, T-band transfer, Deenanath, and syndromic Clubfeet. So thank you very much for joining us today.
How many delegates registered, you think?
Ashok?
Around 800.
Say it again.
Around 800, sir.
Oh my goodness.
They're still learning.
They're still
Open
learning.
a topic.
That's excellent. Maybe I would have expected more questions from them, to be very frank, if 800 were on.
We stream it on various platforms. That's why questions are difficult to collect.
Okay, got it.
Great. Thank you, guys.
Thank you. Thank you very much. Ashok, we can end the meeting.